And your mic is not on.
Okay.
There we go.
I think it is on. I think we're trying to figure out the angle so that he can see it. It's kind of awkward because we're not up high enough. Sorry, are you going to be able to see it there? No. Okay, yeah, sorry. I was just poking the hole. I wasn't injecting yet. So we're going to do a couple different things to her. I know she's laying flat. She has some mild tear trough deficit and a little bit of texture that we need to improve, so we're definitely going to do under eyes. I'm going to do a little bit here in the preauricular hollow. Go ahead and smile for me. I want to do a little bit right here through this smile line zone in that area and a little bit in her nasolabial folds. So those were the primary areas when we were doing her analysis ahead of time. Her tear troughs are not that bad, but then I'm not sure if you guys can see at this, it's that slight texture that she has underneath here. So that's part of what I'd really like to address with her. And so same thing, I tend to use a cannula. So I'm going to try to stay out of the way of the camera, so just let me know if I'm getting in that way. Good. Ready? You're going to feel a little bit of pressure as I glide across. And so because we're using cannula and we're more of that subdermal, that's what's going to make it safer and more comfortable for our patients. Sorry, I know a little sting right in here. Ready? Good. You're going to feel it go. Perfect. So a lot of times, if you guys see me, my finger's going to be on there. I like to feel as I inject. So as I'm injecting, I'm feeling it come out underneath my finger. So I know that might make it a little bit hard for you guys to see. I'll try not to do that in all cases. So I'll inject a line of it, kind of come back, look, see where I need to go again. So sometimes I just go straight to fanning if I can see it, and other times I stop and look. And then I got to find that little hole. It's always good when they don't bleed, but sometimes it's...
So for the panel members, any comment on her technique? Do you do it differently? Is it pretty much the same? Who wants to chime in?
On Ann's technique?
Yeah.
I use a 25 1.5 gauge needle typically. That's kind of my go-to for derma. Unless I do the lip lines, the vertical rhytids, I tend to go to the Radius needle or the 27 gauge thin-walled needle. You just get a lot less clogs that way. Yesterday we weren't fortunate enough to have those, so we used the 30 gauge, which did work, but it does take a little bit more plunging and also mixing along the way. But I think where you use, where you want to use a cannula, you can. Sometimes in the lateral aspect of the jawline, I will bolus on top of the bone with the needle, and then typically when I get in front of the mandible, I will, in this more inferior part, I will use a cannula as well, just because of vascularity and the risk of occlusion there. So, but most of the time, I do tend to use a cannula when using this product, 25 1.5.
So Lee, you mentioned using cannulae. So do you use cannulae everywhere or just in the inferoral area?
No, and I'm glad you asked that because I do use a cannula in the lower lids. Sometimes if I'm lazy and I've got the cannula on, I'm using it in some other areas that I'm very comfortable using a needle in. I still use needles with fillers in the nasolabial fold and many places around the face, just using the same common sense principles. And like anything, you really need to know your anatomy, and particularly where the larger, arteries and veins in the face that you can get a cannula and a needle into. But no, I use both, and when I'm using it kind of as a filler around the face, I tend to do it with the same needle that I do with a filler. No, I use both of them.
Peter?
Well, cannula is an art, and if you're just using needles, try to increase your artistic ability and move on to cannulas because they're safer and there's more things you can do with them. Not all cannulas are made the same. TSK are sharper, have a smaller lumen, so a little harder to push through a TSK if that's your favorite. The DermaSculpt ones are a little duller, have a larger lumen, so those are a little easier to push through. I mostly use a 22 gauge, 2 3/4 inch DermaSculpt because I'm trying to do large areas of the face. So it's a little intimidating the very first time you use it because it seems like it's so large. But the holes heal within 24 hours and they're imperceptible. I also push it through a 25, very rarely a 27.
I'll keep asking.
I agree with Missy, a 27 gauge needle works well if you're trying to chase the rhytids around the upper lip. Yeah.
How many people here are using cannulae, whether with fillers or with this stuff? Okay, good number, okay. And how many people use solely needles?
10.
Very few. So I'm going to give you, my bias. It's just me. So we were one of the FDA study sites for Allergan's Voluma trial, when they actually looked at cannulae, which was the 22 gauge you're talking about, one side of the cheek and the standard needle, I think it was 27 gauge on the other side, looking at clinical results and looking at potential side effects. And so it was an FDA trial because they wanted to get their labeling for cannulae as well as the filler. I will tell you the results are identical. The incidence of ecchymosis, rare on either side, but identical. No thromboembolism anywhere. And so I started way back when there were only needles. I kind of moved over to cannula because I think there is an artistic part to that. And that trial convinced me that do what you want to do what you are comfortable doing. In the end, it's whatever you're good at because either approach is fine. So, Anne, how about you? Are you solely a needle person? Do you use cannulae?
Do I what? Sorry. What was the question?
I got it right. She was injecting somebody. I said, are you only a needle person or do you use cannulae sometimes?
No, I'm using a cannula right now. I use cannulas in a lot of areas.
I didn't see that. Okay, you are using cannula.
Yeah, the lip is the one area that I'm mostly needle, but in a lot of other areas, I'm primarily cannula.
Yeah, and I don't think there's a right or wrong. Any questions out there?
So everybody out here probably does lips, if you do fillers at all. One of the unique benefits of this autologous gel filler is that it actually adds redness to the lips. And it plumps the lips in such a way that it's not hyaluronic-like. I get women who are over the age of 50 that are totally fearful of getting their lips done because they don't want to look like them.
That's a look.
That is a look. That is a look. But what this does is it gives you a natural lip. And it is a little swollen for the first day, but through the magic of PRP, 90% of the swelling goes down the next day. And that the bruising of it is minimal, and it does a great job on the wrinkles of the upper lip. So total perioral rejuvenation is an easy way to get started with this product.
To add to your point, too, when I first started using Derma, or we tried Derma, I was thinking in my head, because in the past we've done a lot of Easy Gel, and I was thinking that the process was going to be the same. So with Easy Gel, we would bring a patient in every 4 to 6 weeks for about 3 sessions, and that's when they're to their kind of magic spot where they're going to stimulate the most collagen, and that will happen over the course of 90 to 120 days. And so the biggest switch in thinking for me was that Derma was different in the sense that you do not have to inject the patient on that 4 to 6 week schedule multiple times. You can do it one time, or you can add a second subsequent treatment in within that second month and extend the longevity of that fill look part of the product even out further than 6 months to more of that 9 to 12 month mark. But I will say with some of the other fillers, regenerative fillers, I wasn't getting that 90-day mark where they still look filled. Now the patient would come back and the skin integrity might look different and the color might be improved, but I wasn't seeing the fill part of it. And so the patient would be saying to me, well, the filler part of the Easy Gel is gone, but my texture's better. And so Derma will give more of that filler hold to the tissue longer than some of the other products. So that was a bigger learning curve for me to not think I had to bring them in every 4 to 6 weeks.
So I focus in on this, this more natural look, and I think it's so true with the upper lips. I mean, I just see these people come in, in my neck of the woods, and I'm sure it's true everywhere, who just have the goofiest looking lips. And it's always a hyaluronic acid because nobody puts sculpture radius in there. And they just don't get that with this. They get a very natural look to them. So one of the things I want to pose to the panel is, and we'll get your question, I see your arm, is I've done PRP now for years, and I'm switching people over to this, and I'm charging more, okay? And so how do you handle the discussion, particularly those people who've had PRP before, how do you handle the discussion about how this is different, and therefore I'm going to charge more for it?
I really look at it as a much less expensive product. Now, they're paying a higher cost up front, but, what are most of you all paying for a tube of your filler? $200 to $400 to $400, depending on what it is.
Not in New York. Oh my God, my overhead is way too high for that.
And honestly, I'd have to ask my office manager, what's our cost on a 22 mil kit of this, our cost? About that, I think. Yeah. So we're getting 1 cc of filler for $250 that you're, or $400, whatever you're getting for, and charging more. And with this, you're getting, 12, 13 cc's of a filler. Not only that, an HA filler may be stimulatory in some ways, and I think that's maybe true in some people, maybe not true in others, depending on age and a multitude of factors. This, in everyone, has these really wonderful physiologic effects. So you're getting that you don't get. And the other thing, when we were talking about and kind of alluding to this whole idea of filler face and lips that look abnormal and nasolabial folds that look very, very thick and full and non-mobile, what's amazing to me about this product is I can put 13 cc's in the face and not worry at all, and this is, I really mean this, not worry at all about having an abnormal filler face look. Now, sure, it has to be done artistically, it has to be done carefully. Whereas I've seen people, that have been to places and get 2 or 3 cc's of filler and look awful. So it's amazing that this product is so forgiving. And the other thing,
because it's physiologic.
Yes, no question. It really is, and it makes a huge difference. And the other thing about it is, and why I say I'm still trying to figure out where I can't use it, is you can take this one product and I can use a needle and inject intradermally, so for vertical lip lines or anywhere that I have, very, very deep creased superficial rhytids. So I can use it intradermally, like I would maybe 1 tube of filler. I can use it immediately subdermal, like I would with nasolabial folds and so forth. I can use it kind of in deeper fat compartments in the face, or I can use it down around the periosteum. So, with this one product, I can go anywhere on the face. So I think all of us early on, when we were on the phone with this product, kind of brainstorming on it, at first when we had the 22 mil kit and you're getting 12 mils, you're thinking, what am I going to do with 12 mLs of this? And very quickly, within weeks, we were all saying, I could use more, because you really can use it in so many layers and really sculpt with this in a way that you can't with a filler. Sorry to be wordy, but I'm pretty excited about this product. I really like it.
And if you think about the price, if you're bringing a patient in, we charge $1,500 for Easy Gel, and you're asking those patients to come in 3 sessions, so it ends up being $3,500, $4,000. And if you're charging pretty much the same, but you're offering even a longer lasting result, and you're getting 3 times as much, because I don't know of any other product that yields 11 or 12 cc's of usable product. And I think when you talk to patients in that regard, if you show them those syringes and you go, if this was 11 or 12 syringes of filler, I mean, this is, think about the cost on that. So they're very savvy when it comes to that. And I think more than ever, people are very aware of what they're putting in their bodies. And so it's just perfect timing, right? Because everyone now wants to go to this regenerative aesthetics or regenerative medicine model. And so for us that have been preaching to the choir a long time with biostimulators, whether it was Radius or Sculptra and our autologous fat grafting, all those things that stimulate or biomimic, it's the perfect opportunity for you to capitalize on that, and you have a biofiller. And I don't think that they mind they're paying a little bit more, because they end up paying a lot less, because you're not offering just a filler, but you're changing the skin integrity of their skin and doing so much more for the anti-aging process.
Peter.
Yeah, so one of these is equal to probably 3 Sculptras, I would think. So if you're going to come in and do 3 Sculptras, you can pretty much charge that. I've been still playing with it, so I'm not quite solid on what my pricing is going to be, but I at least charge $1,500 for it. And with this, once this voluminescence comes through, and people get excited about it, I think they're not going to have any problem wanting to do more. No one's excited about coming in to get their next Sculptra, but I think they're excited about coming in to get their next.
To answer my question, and again, I don't know, everybody charges different prices PRP. I'm pretty much charging double for this because I do believe it does so much more. I think you get longer lasting results. I mean, I don't, like I said, I add PRP to all the other stuff I do. I think this stuff does something in its own right beyond just PRP. So there was a question over here. If we get the microphone over here.
Here we are.
Right here.
Okay.
So we have had a demonstration of the competitor that she's speaking of, the Easy Gel. It didn't go very well. The block was not well heated enough, and we didn't have a good product at the end in order to inject, that I was comfortable injecting at least. What is the failure rate of the Derma PRP in terms of if it doesn't process well, you can't inject it, it's too clumpy?
You didn't get the gel. Is that what the issue was?
It did not
right.
gellify.
Which I haven't used Easy Gel, but I've heard that.
It looked very
PRF?
odd, and I just didn't feel comfortable injecting it. It was very chunky and almost like cottage cheese.
And
Would not have gone through the cannula at all.
So I've not experienced, sorry.
I haven't seen a failure rate, so there's no failure rate with this.
So
Euro?
we've had
Is that in writing?
So the only reason there'd be a failure rate in that product, it can be based on somebody's hematocrit health. Because we're dealing with plasma, and has anybody ever donated plasma? And they look at like the color of your plasma, and sometimes it's very cloudy. So the only time we've ever seen anything, we haven't really had it in the U.S., and there were small reports over in Europe that the gel would fail per se, because somebody's poor hematocrit health. Somebody eats a really fatty diet before, or drinks a lot the night before, or something like that, or has a higher fat content in their blood. When you spin it down, it looks a little more foamy, and it doesn't quite gel up a lot. It's because plasma does carry.
your mic's off.
What's that?
You lost your mic for a second.
Oh, plasma does carry some fat in it, so it might foam up and bubble. But typically, you could probably redraw that patient with a smaller kit and still spin it down or heat it a little longer. I'm curious as to a true failure rate. We've never actually seen it in 5 years. So it's been researched since 2018, and then it's been utilized in Europe heavily for 2 years, and here since really March or April. So we haven't really seen that. But we have seen issues in PRP with some patients in general PRP just because of their hematocrit health, so depending. That'd be the only variable.
You can usually tell that when you spin their blood. You immediately can kind of tell if their cholesterol is high. I mean, you can just automatically tell before you ever start the process.
Yeah. That's a good question. Thank you for asking.
Yeah, good question. We got another one. I'm coming right to you.
What's your protocol if there's an occlusion?
I love this one. Okay.
Wait it.
I have jokingly said from the podium, if that happens, you immediately pee in your pants and call your attorney. It's not a very practical answer. So go ahead, if there's an occlusion. And I think she means not an intravascular occlusion, but the more common sort of compression occlusion where you see some blanching, they tell you it hurts. How do you handle that? Because obviously that could occur.
So I would handle it the same way that we would treat an HA or any vascular occlusion or vasospasm. We would do heat. We would do Hylenex, because Hylenex is just going to dissolve the hyaluronic acid in that area, making more space available to vasodilate if necessary. Heat and Hylenex is kind of our go-to. I guess you could do nitroglycerin, I think, is here nor there now, right?
So I'm not sure I've ever even heard of and I may be wrong on this, forget about this stuff. I'm not sure I've ever heard of a PRP-induced occlusion either.
I never have either. Yeah. Now, with this product being more gel-like, common sense makes you think that, it could occur. But, I think at this point, I would agree. I would treat it like an HA occlusion. And certainly if you have a vascular occlusion, with vision loss or impending tissue loss, then, those patients, unless you can handle this in your office or your clinic, probably need to go to the hospital and have some, thrombotic therapy and so forth, heparinized, maybe even acute thrombolytic therapy.
I think many of us have seen the more typical compression type occlusion where they complain of pain, they get blanching.
So this product altogether compared to HA fillers, which I still use and, and love, but is more forgiving in that sense completely. And I don't, it's early in the process. I'll be surprised if we see that as an issue with this.
We haven't had one in 3 years.
Yeah. I'm not surprised.
So they never had one in Europe. I spoke with the medical director actually very recently in Israel from the Estar Medical Company. They said in all the studies And in almost 3 years now that they've been utilizing it in Europe, they haven't had a single occlusive event, and we haven't had it here in the United States as well. But it's pretty much kind of the protocol like you talked about. They recommend if it were to happen, saline flushing, massage, and heat. You know.
Well, because in theory, hyaluronidase is not going to do much for it.
No, not for that. Yeah.
So,
But again, this is a physiologic process where all the fillers are really foreign bodies being injected.
Right.
So they are different.
it's important to have a moving needle or a moving delivery device. Larger bore cannulas are safer. Stay away from high-risk areas like the glabella and around the nose.
Yep. We got a question over here.
I did have a quick comment. It has been reported in the literature that PRP into the face and into the scalp for hair has caused ocular occlusion and blindness. So it's not, I can't speak to this, but generalized PRP injections into the scalp and in the face or facial rejuvenation have been reported with for ocular occlusion.
Here we go.
Makes no sense.
Right here.
I have a totally different question. How was the face numbed up? What was used?
We used local, and then I used a little bit of Lido with epi injections at the ports where I was going to create the opening for my cannula. Sorry, buddy. So that's why she has a couple spots that are blanched right where I was putting my ports in.
One thing that I've seen a couple times now are nodules that have come from Sculptra and really being disconcerting because it's been under the eyes or in the cheek area. So this seems like a nice alternative to avoid that because it's been a little messy, with those nodules forming from the Sculptra.
So I'll respond to that first and then listen to what you all have to say. First of all, I don't think sculptures should be injected into tear troughs anyway. For that matter, also upper lips, because that has been reported as a problem. And then once you get them, you're right. I mean, they will eventually go away, but it usually is years. I mean, you're never going to see that with this stuff. So,
Correct. Yeah, you're not going to see that with this, at least persisting.
Ready for my other.
Maybe this is a good time to lead in talking a little bit about viscosity. If any of the AMP guys, give me a signal, I'll stop talking about it. But
go for it.
Serendipitously, when I first used it, I didn't heat the PPP long enough, so it wasn't very gelled. But I was doing this on an employee. For those of you all that were here yesterday, this is redundant. But it was thinner, but as I mentioned, I use a lot around the eyes, and I'm going right under the skin, between the skin and the orbicularis, which, at least in my hands and doing a lot of surgery in that area, is the only area that makes sense to inject. So I like the idea of it being thinner and less clumpy, if you will, or easier to inject and more fluid, which has led to this kind of obsession now with fooling with the time that I'm heating it to get different viscosities or varying the percentage of the gel PPP you're using versus the very liquid PRP as to what viscosity you want. So you can get very thick and viscous with this or very thin. And you think, well, what's the difference in very thin? We're still unwinding that albumin protein. I think the scaffold is different. When you look at what albumin really does in the blood and carrying vitamins and enzymes and so forth, I look at this as kind of a scaffold for where the PRP is setting up and doing the things that it does. So, you really can vary that viscosity a bit, which helps with clumping, particularly if you're doing intradermal injections or anything very close, right? We don't notice the clumping down deep along the periosteum. It may or may not do it. We don't know. But that's one nice thing, again, about the usefulness of this product is that you can really vary that viscosity, and I'm finding that very useful in my hands anyway, that I can do that.
Yeah, if you cook it for longer, it can be thicker, but you really don't need to do that. If you just do what the directions say and do it for 10 minutes, you can inject it intradermally. I agree, maybe thinning it out around the eyes. I haven't had enough guts to try that yet.
Yeah,
but,
right.
Monday.
I have two questions in the back, right here. My first question is, do you have a recommendation of patients who are on anticoagulant medication should stop like about 3 days prior to this PPR injection?
I mean, in that sense, I don't treat this any differently than any other filler. I have given this and other fillers into people who are on aspirin who will not come off it, which still boggles my mind because I don't believe that does anything. And they might get more black and blue. It's not going to lessen the response, and if anything, maybe they'll get a little bit less black and blue. But I try to get people off any anticoagulants. I just don't want to look. And most of the people who do this, frankly, are not on anything really significant. I mean, they're not usually taking Eliquis or some of those other things. What do you think, guys?
I don't. If they're on anticoagulants, I've still injected them. I mean, you're injecting platelets, so it's gonna clot. I don't adjust it for any of my fillers.
We had two questions back there. That was one.
The second question is, a patient is sensitive to the epi in the typical lidocaine. Could we use the alternative carbocaine or mepivacaine? Because some patients do get heart palpitations.
I think any cane you want.
You do not have to numb the ports. That's just a personal preference, meaning you can use zero lidocaine at all for the ports if they're super sensitive. There's some injectors that never numb ports for cannulas, so it's also completely fine to skip it and just use topical.
I mean, to me, the advantage of lidocaine is it's quick acting, kicks in very quickly, but otherwise they all work.
Yeah. Any cane you want will be fine.
I agree. Yeah, I don't think it matters.
Question over here. Okay.
Let's get Rob's mic on. What number?
One more little pinch.
7. There we go.
Thank you.
I was just wondering the skin effects of injecting. As when you do fat transfer into the face, you sometimes see the whole face look more luminous, even though you haven't injected fat into the whole face. Is that the same thing you see after this? Does the skin look better all over the whole face?
That's a tricky question because when you're using 22 cc's, you're kind of having the opportunity to inject almost the entire face or most of the face. Similar in the sense that wherever you're placing it, I don't think it's just literally going to stay in there, but that scaffold extends beyond where you've actually placed the product. And so they tend to look better for sure in the areas that have been injected specifically, but even in the overall area, I find that they look better. Similar to, let's say, when you do Sculptra in the temples or use a biostimulator in an area, you're going to get that kind of wash effect in that entire region where you've done the product, or used the product. So you typically see an overall luminosity change. Now, with that being said, if you treat the temples around their mouth, is that going to look more luminous? And I'm not sure that it would. But if you're globally treating the patient, I do think that those effects extend beyond the actual area that you're using the product, just because of the tissue itself.
Now, I had a patient with rosacea that I injected, and it was clear from her before and after photos that her nose became less red. And I didn't inject her red. I didn't inject her nose. I injected her preauricular and her nasolabial folds. So there probably is some stem cell-like effects happening over the entire surface area, certainly wherever the blood flow is going in that area.
Yeah, and I would say don't underestimate that. That's one of the real things that's very, very different about this product that you don't get with a non-autologous filler. I'm a big fan of autologous fat. I started doing fat consistently as a plastic surgery fellow after Sidney Coleman came down and schooled us all at Emory on the benefits of fat. And at that time, nobody was talking about these other benefits. The only other person who was really making headways was Gino Rigatti in Italy, who was injecting for breast cancer reconstruction in patients who had been radiated. And y'all have all seen radiation changes in the skin and what they can do. And it started, changing that tremendously. Basically, I'm seeing the same thing with this product. So my answer would be unequivocally yes. I think I'm seeing an improvement, kind of in that area, globally in that area, if that's not contradictory. But
Perfect.
Yeah.
We got another question over here.
I just wanted to check in with the patient. I know yesterday we had a few of the patients saying that it was burning, even though it's supposed to be physiologic pH. So I just was curious if the patient's feeling any sensation with the injections.
What's going on over there, Dr. Watwood?
How's it been? So are you feeling burning with the product or just the pressure from the cannula? So her main discomfort's from my cannula. So she said when the product goes in, she's not feeling any burning or stinging, but just some of the pressure or the zingers as I'm manipulating cannula in there.
Sure.
Yeah, we have a question over here.
I haven't seen it burning in any of my patients, but I do blocks on them all. So.
Yeah, I haven't either, but I think you get that probably that sensation when you're doing an intradermal injection, right? I mean, they hurt more, so it may have been yesterday. Whether I don't know what they were getting, but if they were getting an intradermal injection, then
You're gonna feel it more.
they're going to feel that more, just like any kind of intradermal injection. But just in general, I haven't really had that complaint really, and not a lot with filler either.
Yeah.
So much, with HA fillers.
How long would you wait after either Sculptra or fillers to do something like this at the same tissue level?
I think you can even do them the same day. There's a lot of discussion around even using the 22 ml platelets to hyperdilute if you're using another biostimulator like Sculptra or Radius instead of using saline. Why wouldn't you use that? So I have no problems in our practice. We'll stack it in the same day, or you can even dilute your fillers with, using this product as well. So.
We got another question here.
Yeah, stack them.
Hi. So one of the problems that I encounter in my practice is the temporal area that shows volume loss and subsequently the sagginess of the rest of the face. So is this product can be used for the volumizing of the temporal foci area or subdermal over there?
Yeah, I mean, I've used it there, and frankly, I take the same approach that I use with fillers. I go right down the bone, and I lift everything up, and you've got this gel matrix, and it lifts it right up. Everybody agree?
I totally agree, and again, I'll kind of repeat what I said before, is the cool thing about this product in layering an area like that is you can layer this in multiple layers where you may not with a filler, something other than autologous fat, but you can go deep, you can go kind of in the deep temporal fascia area, if you will, where there's an expandable kind of space there, and then you can go subcutaneous or subdermal.
You want to sit up?
So,
but just a lesson in the temporal area. If it's been previously treated with a scarification type filler like Radius or Sculptra, the problem is there's this, it's solidified and then you have a tube of the vessel. So if you nick through that vessel, any semi-solid that you inject has the potential to go into that vessel. So even though you're not intravascular, just a nick can get you into there. So be careful whatever you're injecting in the temple if it's a scarified treated area.
Okay, so our patient's pretty much, other than a little bit of swelling in a few areas. So we did the tear trough area, we did preauricular hollows, we did smile lines, and we did nasolabial folds. So we covered quite a bit for her. She was thinner back here, so I put almost 2 to 3 cc's on each side, almost in the same way you would do like a Sculptra to help fill that in the skin texture. But I was also able to really go through and fill the product in these smile lines. This is the zone where I really do not like other products. I feel like if you put too much there with an actual volumizer, when they smile, they look like a chipmunk. And and she's the same as me. We both get this. So I threaded that all the way through here, which is going to improve this overall skin texture, soften nasolabial, so you can see it's a little bit of swelling, not too bad, but with the cannulas in pretty much all of those areas, lips is the only other area that I really like to use needles, her downtime won't be that bad, and she looks pretty good right away. All right, any questions about what we did to her as far as...
Any last questions before we switch gears again?
We got one.
Oh, we have a patient question too, but we'll do this first, and then the patient has a question.
You want to go to the doctor? Question. We're going question.
2 to 4 weeks. Okay. So she wanted to know how soon she can do a scarlet or heat-based treatment over it, and I usually say about 2 to 4 weeks. I want to let everything settle in, do what it's doing, and then she can go right over it with that. Because she's addicted to scarlet, is what she said. Okay.
Dr. Lei, I have a question whether this product will travel, especially if you inject it probably in the subgala or in the temporal area. Will it travel downward? You know how Voluma travels also? after injection?
Traveling of this product?
Mm-hmm.
I haven't seen it.
I haven't noticed it, I mean, just from doing a lot of surgery in that area, there's an area there that's called the superficial layer of the deep temporal fascia, and it's kind of the way you get, from the temporal region down under the zygoma into the face pretty easily. That's the only plane there I can really imagine that this could travel in, and it's what we would call a loose areolar plane, so it has, septi in there. I don't know. It would be
this being
a little
the
bit
lattice,
hard for me.
being that it's albumin in your own tissue, it sits really well very quickly. We haven't seen any travel thus yet in any of the trainings or any of the stuff I've seen in Europe as well. So it's pretty set once it's in there because it bonds with your own tissue so well, because it is your tissue.
All right, final comments, Peter.
Oh, well, so you were talking about competitors. I don't really see a competitor to this product. And, the reason is, AMP does a good job of bringing the latest technology to the...
In his magic bag.
To the forefront, right? So it comes in sizes, right? You got a 6 ml size, and you got a 22 ml size. You can get a lot of surface area with this sort of thing. And, when I first got into this, it was PPP, PRF, PRG. There's just so many PPs going on. So it's a little hard to conceptualize. But the reason it does so well is because of this gel separator. So all the competitors don't have this gel separator. What this gel separator does is stops the red blood cells from coming into contact with the plasma. Now, the plasma portion of it has the platelets down below, and then it has a few monocytes in there that is actually helpful to propagate the process. Down here, you have over 90% of the lymphocytes, which cause inflammation. You have the red blood cells, which cause inflammation. So if you're using any other